Welcome to all of our attendees and our participants in particular. First of all, I'm always grateful for all of these wonderful folks to come and share their expertise on any topic that we have. In this case, we're talking about virtual nursing, and I don't think we could have gotten a better MVP group. The only one we're missing is Ryan, who was supposed to be here and unfortunately can't due to a family scenario, and we are sorry to not have him here today, but we will be speaking with him and speaking for him in spirit. But thank you all for coming and sharing your expertise. That's super important to me, and as everyone knows, it's important to us at Blue Cirrus that we share good information, helpful information, actionable information that folks can take away and utilize in their organizations and your organizations as you go through your virtual nursing programs. So today we have Julie Reister. You can see everyone's names on the screens, but Teresa Rincon, Lisa May, Julie Miller, Carolyn Ragnit, and Fiona Winterbottom. I will be very specific with the Julies because we've already done the mix-ups with the Julies before, so I'll be very specific with that as we go through questions and make sure everyone knows where we're headed. But first of all, let me ask kind of the burning question, or kind of the overarching question, I guess, to get us started. And Julie Reister, I'm going to ask you this question. As a chief nursing officer in your lifetime, in the career, an illustrious career that you've had and are still having, let me put that in the past for you. Why is virtual nursing important, and how can we widen out the lens for people to understand why it is important for nurses and patients?
Well, thank you very much. And I just want to echo your earlier comments. I mean, what a dream team of experts here. So it's a pleasure to be joining. I mean, I was very fortunate to have a position as a chief nurse executive for essentially a virtual hospital back in 2011. So, and I didn't just start it from scratch. So it's important to point out that that program was actually in place for several years before, I joined. And I would say at that particular time, really the focus was on, it was an EICU program, and the focus was really much more on the lack of intensivist coverage and physician coverage. And so what we've really seen transpire, I think, over the course of time is that virtual nursing is having a moment, I think, certainly for folks like us that have had programs in place with nurses who have been in these roles for many, many years. It's really gratifying, to see. But I think, a bit of a parallel with where this started many years ago is, it is really an opportunity to look at the care delivery model in this new world that we're seeing, whether it's with staff burnout or turnover or novice nurses. There's just a litany of reasons why this made sense before and it makes sense now. And certainly the rest of the panel, will talk about it. But it's really, I think, future-proofing healthcare in all of the different settings. I think there's a lot of focus on the inpatient setting right now, but we'll certainly dive into all of those kind of use cases. And it's really about being able to provide even, I believe, better, higher quality, safer patient care. And it's a really exciting time to look at how that role really fits in and can be integrated into all of those settings. And I would just, last comment I would just make is it's not just nursing. I know that that's our focus today, but it was a little bit like a train going down the track even years ago. We added pharmacists, we added social workers, we added translators, we added nurse practitioners, etc. So it's a really exciting area for us to talk about today.
It's really evolving. I mean, we're we're really incorporating more and more clinicians, as you said, into this mold, into this model, and understanding that we can do more things in different ways. And as you mentioned, what virtual nursing is having a moment, maybe longer than a moment, but certainly after the pandemic. And I hate that we always have to measure things by post and pre-pandemic, but that's kind of like life. Given that, it makes sense to look at staffing models and look at operations and see where, we had a real stressor. We had a real stress of our system. Did it work the way we expected it to work? And how can we change that and make that better? And I do think that that idea of widening the lens of what virtual nursing is going to be important in including those use cases. And Lisa May, one of the things that that Julie just said around having the moment kind of struck me, so I'm using it a couple of times, but we've gotten a lot of attention to virtual nursing in the last, few, probably 6 or 8, maybe even 12 months. But which has created a lot of ideas about what virtual nursing is versus what virtual nursing isn't. And maybe not, my question to you is, how do you describe virtual nursing? How do you communicate what virtual nursing is to not only your peers, but leadership and patients?
So I'm going to follow a very prestigious colleague of mine and use her words. That's Teresa Rincon, that virtual nursing is
fair.
nursing. Because that's just what it is. There is no difference in the nursing process than if you're physically with the patient or remotely. What we're using is using those talents and skills that we've honed as nurses in the inpatient on-site realm, and we've taken that to the next level. And so I just wanted to also point out that, we're talking about this newness of virtual nursing, but it's really, I like to see that folks are having a new appreciation of what we can do with nursing beyond our physical touch with the patients. And so when we're talking to folks who are new to or having a new appreciation about what nurses can do, we definitely want to let them know that their skills, their aptitude, their knowledge, their critical thinking, all of those components, those competencies that they've built over time are leveraged through technology to meet more patients, to touch more patients. And it's having an awareness of their role and being set in a setting that they are appreciating, that their contributions are meaningful regardless of the location. I think that it becomes less, there are no barriers. So that's what I often try to do when I am talking to nurses, to leaders, and to explain to them that the mold of nursing didn't break and separate itself into a virtual nurse and an on-site nurse. All it did was take those wonderful skills of nurses and leverage them through technology to meet the needs of more patients, providing access to expert clinical team that they may not otherwise might have access to or can leverage. And we can talk about what happened throughout the pandemic, but going forward, if we're thinking ahead and future state, organizations and leaders need to think about how does 5 years from now look when they're talking about their nursing model, their workforce, their staffing, because telecritical care, med-surg, virtual nursing, all of it, whatever you want to call it, it's here to stay, and it's just moving in another trajectory.
I think it's very similar to physicians. We saw the same kind of, I don't know if this is good or if this is possible, kind of apprehension from physicians and from leadership when we saw virtual physician care being done, whether that was primary care or specialty care. But then it became necessity. So to your point, we need to really think about this future proofing. I neglected to mention that if you do have a question and we would like to make this interactive, so feel free to ask questions in the chat, and we will pick those up. As well, I also have a poll, and I believe I did this correctly, so we'll see if this will work or not. I'm going to launch this poll and see if we can get some questions answered and get a little sense of where our audience is. I see people answering, so I must have done it right. Can you all see the answers coming through as well?
We can't see them, Michelle.
Maybe when I end it, it will show them. So there's two questions that I asked for our panelists because they can't see them, but which describes the current status of your virtual nursing program? Strategizing, planning, building, or learning? And then has your organization determined metrics for your program under financials, clinicals, and operations and staffing? So I'm going to end this and hopefully it will pop up on the screen. If not, we're in trouble. There we go. Share results. Can you see that okay?
Yes.
Okay, great. So essentially what we have is a lot of different people in lots of different places, which is not unusual. What do you see in the results here? Anything that's shocking to any of you?
No, it's in line with what we've been seeing and hearing. A lot of folks are trying to strategize and to see how this best fits into what their needs are, because any program that you're going to develop and build needs to meet the needs of your organization, your workforce, and your patients. So picking a rabbit out of the hat and just whatever, the virtual nursing model, it's not necessarily going to work for everyone. So it makes a lot of sense that a lot of folks are thinking about their strategy and how to align with their organizational mission and vision.
Yeah, I would agree with that. I think we're seeing a lot of people in different stages of this. But what I'm also seeing, and I don't know about the rest of the panel and those that are in the audience are seeing, is a lot of people are jumping into this without really having the experiences or lessons learned that we've been able to gain for the last 20 years. So, anyone on this panel were to jump in and help with strategic planning for a virtual nursing program, we might have a different lens from those that don't have any experience in that space. And so that would be interesting to learn from the audience, and maybe there could be some questions, or feel free to put something in the chat related to that. If you feel like your organization has the expert panel or expert group or some expertise in this area available to you to help you determine your strategic plan and execute.
Anything else that struck anyone? I have one more thought. So
There is a question in the Q&A, Michelle.
yeah, I caught that. Thank you, Julie.
So I know I spoke already, but I think it's interesting that more of the respondents, the participants, said that they're looking at clinical metrics as opposed to financial. We know the CFOs like that return on investment question, but I'm glad to see that, a few people are thinking about that those clinical outcomes that are going to really drive the financials once the quality is there.
Sorry, go ahead,
Yeah,
Julie.
That's okay. I think what I would also add is at this point, looking at the poll and seeing how many people are learning and building and in that planning stage, is that, and even the strategizing, is that what can help with that stage is the AACN expert consensus statement for telecritical care nursing that supports acute, progressive, and critical care nursing. And that is a free download off of our website. All you have to do is register your name and email address, and you can download that PDF for free. But I think that has the standards that look at what do you do as the nurse who's working virtually? What do you do as the leader who's supervising and guiding those nurses? But it also has information for healthcare organizations and how healthcare organizations can help set their programs up for success. And it has some really nice competencies laid out. And then the other beautiful piece in there are the vignettes about how people have applied those consensus guidelines to their own practice and seen the outcomes that have come. So again, that's a resource, and we'll be providing those links after the session.
Thank you. Someone has asked that question. So
Yes.
we definitely will be sending those links in. The financial question, Lisa May, was the one that was interesting to me. So many folks are looking at operations and staffing and other things like that, but not looking at financials. It does drive that, but I think we hear a lot of the time CFOs are really interested in what's happening from a financial perspective on this particular topic. We do have a couple of questions in the chat, so we do have a hand raised, so I'm going to have to kind of moderate. That's my job. For organizations just starting off with virtual nursing in an acute care setting, how do you complete onboarding and training? Since there's not a person who currently does this job, do you train on the units first? Anybody would you like to jump in on that one, Teresa or Caroline or anyone else?
I can jump in. So it was challenging finding a way to do training because we wanted this to be a fully remote program, which includes no training on site because it's truly remote. And so all our training was done online. We already had virtual orientation for our organization, and we modified the inpatient orientation to a virtual orientation. So we had epic modules that were done and required our nurses to do the same modules as the bedside nurses. And then we used Teams to meet and to create different scenarios that the virtual nurse may run into. So we've had experience with tele-ICU, critical care, virtual nursing for over 20 years. So we were lucky we did have that training set aside that we adopted for the acute care virtual nurse training. So a lot of the virtual online tools that nurses will be using, we train them right away using those tools online.
Any other perspectives? All right, I'm going to allow my hand raiser to talk, Deborah Graham. And you are, you should be unmuted or allowed yourself to unmute.
Thank you, Michelle. This is Deborah Graham, but I didn't raise my hand intentionally. So.
Okay. We will take that as a technical difficulty and keep that off my screen, which is great. Okay, well, additional questions in the Q&A, and thank you for your participation, Deborah. The Q&A, I am concerned about how many people are using virtual nursing for staffing. I love this question. Virtual nurses cannot replace bedside nurses. Doing so causes a lot of discord between the bedside and the virtual nurse. Who wants to tackle that one?
I'm happy to jump in on that. That's something that we were dealing with 20 years ago when I started as a virtual nurse in January of 2003 at Sutter Health. And I have to give a shout out to all the virtual nurses, the telecritical care nurses I worked with at the time, because they were so innovative and we learned so much together. And I felt like because we were the first on the West Coast, the second in the nation, we had an opportunity to really set the stage for what even telecritical care nurses would do. So we got to help build that structure, and it was a lot of fun. It was a lot of work, and it was a lot of challenges. And that's one of the big challenges when we started 20 years ago, where literally there were nurse leaders in our organization that felt that once a nurse started to work in the telecritical care unit, they were no longer nursing. And so we had to work very closely with folks like the American Association of Critical Care Nurses to help us define kind of what the practice standards were. And we actually ended up, because of the work that many of us that were in the trenches so early did across the country working with AACN, we ended up with a certification through CCRN specifically for nurses working in the telecritical care unit. So first, I just want to make sure we understand that as Lisa May put so eloquently, nurses are nurses, regardless of where they're sitting, if they're or standing, if they're beside the patient, physically able to touch them at the bedside, or they're zooming in with a camera remotely, they're still able to do nursing. And you're absolutely correct, the person who asked this question. It is not meant to replace nurses. And I agree with you. I get angst when I see either technical groups trying to develop even virtual simulation type of nurses. I mean, we're talking avatar to replace nursing. No, that can't be, that is not what we're here for. But leveraging technology to reach more patients with nurses who have appropriate levels of expertise, right? Because when we know, and I know Julie Miller's probably biting at the bit to jump in, but I'm going to start off with synergy model. When we think about the synergy model, which has been around since the late 1990s of Martha Curley, assisted with the development of that model, I think it was published in 1996. So in synergy, that's the appropriate match between the needs and characteristics of the patient and their family with the skill and expertise of the nurse. And we don't have that every day on every shift in every area of healthcare from a nursing standpoint. And so how can we take virtual nursing technologies and extend expert nurses regardless of geographical boundaries? So when I was at Sutter Health, we covered 500 square miles in Northern California for 24 acute care hospitals. We had critical access hospitals. We had small rural hospitals. We had very small community-based hospitals all the way up to large tertiary care centers. And so how do we make sure that a patient, no matter which hospital they went to, could get the same level of care? And that's where I think virtual nursing can help. So even though, as we mentioned, it first started off because the idea was to spread out the expertise of intensivist physicians. In 2003, when we did this at Sutter Health, what we quickly learned is that we had an opportunity to, as nurses, to impact the care of patients. So those nurse-sensitive outcomes, even though we were remote, we could have an impact to do that. So that's how I see virtual nursing and its ability to support nurses at the bedside, not just with tasks, which is important. We can offload the interruptions and tasks now that impede nurses from actually providing strong assessment and care, right? Skillful care, because they're so busy getting interrupted and they have so many things to do. There are things that can be done virtually to help offload that, but we can also assist as a second set of eyes.
I just to your point, Teresa, that, and I agree with Christy, who posed the question, that virtual nurses cannot replace bedside nurses, but it should optimize the work of nursing, regardless of where that nurse is. And we have so few of those expertise that we need to be able to leverage it in the most effective way. And staffing, if you come out the gate talking about staffing and reducing staffing, the conversation pretty much ends there. So we need to think about, what are we solving for? Sorry, Julie.
No, you're great, Lisa May. I think that's a really important piece and actually helps me lead into what I was going to talk about, which is the healthy work environment standards, and that so many of you are in this planning and strategizing stage, that making sure you build a foundation of a healthy work environment to ensure that the nurses on both sides of the camera feel have ownership and have a part of it. And then I think that because the healthy work environment standards are great for any organization and any unit, and you can actually, if you're planning, you can get those work environment standards and use them as a guide to set up yourself for success. The other beautiful thing that AACN provides for free to anyone is a healthy work environment assessment tool There are currently 2 tools available. There is one for the RN, but then there is one for the team, which means anyone who's going to be on the team, for instance, if you're developing a virtual nurse program, and anyone who might be involved in that team, from housekeeping to the social worker, the respiratory therapist, the nurses on both sides of the camera, you can include them in an assessment of where you are now. And then AACN provides you with a report for you to, with some suggestions as to how to improve, that are based on the healthy work environment standards. So I love that beautiful piece of it. I will drop that in the response to Christy Atkins's question, those 2 links. I will have also added the link to the synergy model in the response to her question. And for those of you who asked about the telecritical care consensus statement, in the answered tab, I also dropped the link to that under Emma's question. So just super exciting resources that I can share and help provide to help you all put on just a firm foundation of building from the best place possible.
Your organization's been doing a lot of great work and has been at the forefront of this and really helping to make nurses' jobs healthier, make them have less burnout, and how to adjust to new changes that are happening as well. So I hope I've characterized that well, but that's certainly my impression. One thing that I was thinking about when this question was asked and why I was so excited about it is I remember years ago working with an organization and helping them to determine what they were going to do with their tele-ICU program, and their concern about their nurses being offended or concerned they were being monitored. Were they looking at their aseptic technique? Were they somehow being recorded? All the things that we heard along with other virtual care services as they came on board. I'm wondering, Caroline, did you go through that, and how did you manage that? And I'll expand to say that in that client and in other clients, we have advised having their virtual nurses really rotate through. Sometimes if you've got that ability to have your bedside and virtual nurses rotating, if you're not kind of doing a different kind of model, to allow them to know, oh, I know that nurse, I've seen them, and I know the work that they're doing, and they can build that trust with the virtual team.
Yeah, I can answer that question. For our telecritical care program, we do have our nurses working both remotely and on the unit, and that does help with that relationship, knowing what is happening on both sides and building that relationship with your partners at the bedside and getting street credit. But with our remote world expanding beyond the hospital walls, we also have nurses that are not working at the bedside, and they're also 100% remote. So that does building the relationship and trust. There's different ways you can do that with team building and integration before going live, and trying to get to know each other in different ways online, and having your nurses join meetings where you're creating the workflows together and having that accountability towards each other. That's how we've dealt with that. And the other question was, or for virtual nursing in the acute care side, it just like tele-ICU, lessons learned is we don't have time to be watching one patient and one nurse for the whole 8 hours. We always make sure that we are not telesitters. We are using our skills to help be extra resources to supplement your care. And we have a list of those different ways. So medication review, patient education, and those discussions where we're involving the patient, but also inviting the family to join us with our technology. So having a video conference with the patient in the room and family. So we spend a lot of time doing that. And your nurses will begin to know that our virtual nurses, when they support the bedside, they can't be watching and being behind the scenes with each patient for an extended time, because we are having those discussions with the patients and they're aware of it. We do have rounds, and patients and nurses are aware that we're going into the room because we do have a doorbell and we do ask permission before entering the room. So we're not big brother, we're not big sister looking at aseptic technique unless we're asked to. So one of our interventions is the safety pause. And yes, we are looking for procedural technique and being the remote witness for that. So in that circumstance, yes, we do that. In other circumstances, we're spending time with the patient or family member and they're aware of it. And other times in the tele-ICU, we do rounding and it's like we're a charge nurse going down the hallway, looking into the patient room with the window open. We're not always knocking before looking, but we can see the patient through the window and we're doing like quick rounds that way. So when you're rounding on the camera, it's akin to that. We're doing safety checks. We're not there to be like a telesitter where we're having continuous surveillance.
Bit more of the big brother used to feel that way. That's not, we're now part of, this is part of the team. This is part of the modality of care. We have, as we expected, quite a few questions in the Q&A. I want to go ahead and hit those. One thing that someone has asked here is, what would there be the possibility of using nurses who typically don't do critical care, support critical care nurses with many tasks which take time to complete? And what's the opinion of the panel on using virtual nurses from overseas? Any concerns there? I'm going to hit the first question first. I think I'm gonna, Teresa, I'm gonna let you hit that one really quickly. If you have a nurse that's not doing critical care and they're gonna support a critical care nurse, what are your thoughts about that?
Well, I think it depends again on what's the problem you're trying to solve. And if the problem you're trying to solve can be done in a team nursing aspect, even virtually, then you may be able to use nurses that have less experience. But in most cases, what most people are trying to do is disperse their expertise across additional units, hospitals, geographical spaces. So what we saw even 20 years ago, there were B units, especially a night shift, where the most experienced critical care nurse had 6 months or a year of ICU experience. So, you know, in that case, having that expert critical care nurse that can serve as that e-coach and e-mentor for all the nurses on that unit and assist them with setting their practice patterns. You know, if you think about what do expert nurses do, expert nurses set the practice patterns for the healthcare organization and at the individual unit level. It's your expert nurses that are hopefully well immersed in evidence-based practice, and they're acting as your translators for evidence, you know, what's happening out there in the research. So those nurses that are going off to NTI, the AACN conference that many of us just came back from in Denver, they're going to that. They're going to Society Critical Care Medicine. They're going to their other if they're in the medical surgical world, they're going for that. If they're in the emergency room, they're going for the ENA, and they're getting these advanced certifications in trauma, neuro, critical care, etc. Those are the types of nurses that can assist in setting practice patterns. Your CNSs, you know, your clinical nurse specialists, your DNP, your doctors of nurse practice nurses, those are the types of people that are helping you do that. But if you don't have enough of them, right, how do you spread them out? And that also gets us to the opinion on using overseas nurses. Again, are they going to have the expertise and knowledge to fill the gap you're trying to fill? So again, it goes back to what's the problem you're trying to solve.
Yeah, and you also, for that second question, you also need to understand whether or not there are any regulatory or compliance issues with using nurses from overseas. We know that the provider side is pretty much regulated. It's pretty clear what they can do. But as far as the Nurse Practice Act, you know, having a nurse that's licensed in your state but is working or outside of the United States, is that something that is allowed? So you need to look at your State Practice Act and to figure out if that is okay. And just to add to the point that Teresa was making to the earlier question, and just to really reiterate about the synergy model. So having an ability to plan out your your virtual nursing model to meet the needs of your patients. If it turns out that having a skill mix that includes critical care, med-surg, ED nurses, whatever it is, if that mix is going to meet the needs of the patients and are aligned with the patient's characteristics, then that model should be okay. So it's just a matter of looking at your patient population and what their needs are, and then your nursing population and what their abilities are, and do they align, and is there synergy to be found there? You can become quite creative, I think, and it's just a matter of streamlining and connecting the right dots, and not just doing it because that's the way we've always done it, but we're doing it because that's what's best for the patient and for the team.
And
Right.
just, Michelle, just to tag on real quickly to Teresa's earlier answer about using non-critical care nurses in critical care, we actually stumbled upon, because back in the day we weren't maybe thinking about this as sophisticated as we are now, but in that role that I had as CNO, once our service line expanded beyond EICU into med-surg, we did have examples where it was maybe a second check of high risk med, maybe it was bundle compliance. There were things that started to pop up on the critical care side. And, we were in a physical environment and had communication set up in a way that the med-surg nursing team became aware and raised their virtual hand like, hey, I can do that. I mean, so there were things that kind of evolved over the course of time that as this, program grew and the roles grew, we had an opportunity to do that. We didn't go into it being as smart about thinking about it, in that way, but there are opportunities, that can, certainly arise. And once we start to talk a little bit about the communication handoff, I'm happy to talk a little bit about some of the lessons that we learned back in the day. And I'm sure that like Caroline and others have some much more sophisticated ways of doing that now.
Yep, I'm saving that. I'm kind of trying to evaluate the questions as we go. One question I know that Teresa's typing an answer around is around our mature acute care centers and telecritical care operations billing for those inpatient services. And Teresa, you're typing that answer, so I would want to jump to you so I don't conflict with what you're writing. I'm sure we wouldn't conflict, but.
Basically what I'm saying, and I'll put it in the chat for folks in case they want to look at it as well, but billing for any inpatient service, right, regardless of whether it's telehealth, but telehealth has its own little specific nuances and problems, is dependent on CMS, individual state, and payer specific requirements and regulations and standards. So while many are trying to build, some are trying to bill, and they're billing for some specific services, like one of the easiest ones to bill for off the top of my head would be telestroke, because it's considered a standard of care. So there is an ability for the remote providers to bill. Now, not all of them are doing it because it's cumbersome and it's a little tricky, and it requires some very specific documentation in order to bill for those services. That is one way an organization can negotiate with their telestroke providers to say, you know what, we're going to have you bill. We're going to treat you just like any service as if you walked in the door, and we're going to have you bill to offset the costs associated with your services. So that's possible, but it is difficult. And as Julie Reister knows, it requires some negotiation with the third-party payers, which she had some successful experiences with at Banner. So I'll leave it at that, but it's a complicated discussion that probably we could do a whole hour on.
And that's a great segue to the fact that we will do a part 2, which is around redesigning your virtual care, virtual nursing processes for success. Now that we've had this question around payer and reimbursement, we can certainly include that as a piece. But generally, I would say, and my background is not nursing, it is IT and financials. I would generally say we're usually under a DRG in those cases. So it's unlikely that those are being billed. But we will clarify for our next part too. One thing I want to mention before I go to our communication warm handoff that Julie's going to pick up, Christy Atkins, who asked her question earlier, wanted to clarify what she was asking or saying, and I think she's clarifying her question. So I want to make sure that I'm communicating correctly, and she can communicate if I am. She said, I'm seeing virtual nurses paired with a bedside nurse, and they are given a larger assignment on an inpatient med surge floor. So Caroline, I know you picked up some of the question that she had asked earlier, and I think that statement is true in that they are able to be paired together and have this, teamwork, but I want to make sure you have a chance to answer that.
In our system, yes, that is true. However, we are adding a CNA or a nurse's aide certified to that team. So we are adding additional staff. So both nurses can work at the top of their license. And by doing this, we do see more engagement with the CNA and the nurses and delegation. So with that model, you do have to have the model hired beforehand. So typically you would hire your CNA and have that dyad with your nursing and then add the virtual nurse on top of it. So we're adding resources to the existing nursing team so we can better use that ratio with folks that have the licenses and the delegation skills.
Thank you for that. Appreciate it. Okay, so one question before we get on to the really around making systems better and picking a system and how do we make those more efficient. So Fiona, I have you on deck, but one that's in the Q&A that Julie referenced I wanted to pick up really quickly is, does communication or warm handoff what does it look like for your organization between the virtual nurse and the bedside nurse to maintain that seamless continuity of care?
And which one of us do you want to answer that?
Sorry, Julie Reister. I'm sorry, that was you. You had mentioned the warm handoff communications, but
yeah, I'll be real quick because there's others that are going to have, like I said, a much more current and sophisticated approach to this. But this was so important and continues to be, I think, so important. I mean, back in the day, many years ago, there was the traditional handoff of the bedside nurses. And, to be perfectly honest, when I first entered the realm of being the CNO of a virtual hospital, that same kind of rigor did not really exist. It was kind of like, hey, things are going really good and I was behind the camera and I had a good night, and one person would be gone maybe 10-15 minutes before the other one arrived. And I was like, wait a minute, I don't think that's how we're going to do things here, right? Like, let's go back and think about this. So, we really standardized the virtual nursing handoff in very much the way that it happened at the bedside, because that was just kind of my kind of sphere of thinking at that time. And that was one thing, right? But then the other piece that we had to be thinking about, which gets to this point, and I'm really excited to hear from others, how that's happening now, is, well, yeah, but like, how does that work, across nurses that are behind and in front of the camera? So we experimented with a lot of things. A couple of examples that I will just give was that because the virtual nurse was responsible for documenting, just like anyone else would in the single source of truth in the EMR, it was transparent from the perspective of the documentation, what it was that the virtual nurse had done, what their observations were, et cetera, et cetera. But that really kind of wasn't, enough. So we tried to figure out ways where there could be a video connection during, early in the morning, with the patient, another one with the nurse. So, I guess my point being is that we really struggled with that because we knew that it was so very important. And I think, like Caroline talked about, developing relationships. And it's not as easy now as it maybe was back then, where you could have someone who was rotating in and out of, the hospital, and why it was so important for us to interview for I'll call them soft skills. Like, we interviewed virtual nurses. Part of their interview process was on video, because we all know, we've seen the spectrum of that. So, I'm really excited to turn it over to the rest of, my colleagues to talk about, now in 2024, what does a really solid communication handoff between virtual nurses and the bedside look like?
Yeah, I think Fiona's got some good practical stories that she can tell about the work at Ochsner, specifically with sepsis, right? Because it's a complex disease state, difficult to detect, and what happens when you have virtual nurses assisting with that kind of care. And so maybe, Fiona, you can talk kind of practically about what you guys did and what happened and how you solved some of those communication issues.
Yeah, looking at some of the questions, there was another one that just popped in the chat too about witnessing the bedside nurse and cutting down on documentation. I think that's where we've seen a large amount of success. So again, learning from our tele-critical care programs, we started ours in 2012. So we were a little later than some of the others on this, on this webinar. But we were looking, what problems are we trying to solve? And it wasn't problems we identified. It was problems that the staff identified, right? So we wanted to know what is going to help the staff, because sometimes we're not always doing that, asking what's helpful, and then we create solutions that are not helpful to them either. And so one of the things that was very early on in our adventure was we actually got our EMR and our tele-ICU in the same month in 2012. We went live with all of it at the same time. And what we quickly found was that as people were learning their EMR and how to document, it was a struggle. And I'm sure that's no different for anybody else who's got a newer EMR. But documentation is challenging because nurses want to take care of their patients. And so trying to figure out where you can support the bedside is really important. So Code Blue was early, very early in our journey. We found that if we could do Code Blue documentation for staff, it helped them leave on time. It decreased stresses at the bedside. It meant that they weren't back charting. It was immediate. Like, there were all those things. And then anybody else who's not at the bedside who needs to know about those patients has the information, because now it's in the EMR. Because as most of you know, when you get into those emergency situations, your documentation might not go until after your shift is done, because you don't have time to keep up. So we were very effective with that. We started to figure out other ways to help the bedside. So what Teresa was just talking about was, sepsis is a problem. We have different types of alerts and AIs and things like that go off in the chart. But again, adding alarm fatigue and burden to the bedside. So we very quickly learned that an opportunity there was to take that burden away from the staff. And literally, instead of saying, oh, you got a sepsis alert, we're just going to let you know about it. Well, we don't even have to bother them with that. We just deal with the alert, look at it. We adjudicate whether it's valid, not valid. Do we need to do more review of that? And then we use internal text messaging to make sure that we've communicated with the staff. So it's taken our handoff, which may or may not be great sometimes, and put it into a different context. We can't order or anything through that mechanism, but we can certainly communicate in a time where the staff is ready to receive the message. Because a lot of times we're sending messages when staff at the bedside are in the middle of doing something else. And it is really, really distracting and hard for them to manage. So we actually measured our sepsis alert burden from the time pre and post. And we kept thinking we were going to need to add more staff to manage the alerts. And what we found was that we just hugely decreased the alerts. So the alerts were answered in a more timely and effective fashion because we weren't constantly delaying them and then just having more of them because they weren't completely answered. So, you know, it's a bit like putting the snooze button on your phone and you don't want to wake up. Well, it just keeps waking you up, keeps bothering you until you wake up. Well, it's kind of a similar concept. So we just took that away from the bedside for it not to bother them. So that I think some of that, and then we've done a lot of pilots of things. So we pilot a lot. I'm like the queen of pilots. Because if you try something, you need to fail fast. And that's the only way we learn. And so I think a lot of these things are, did it work for the bedside? If it didn't, okay, how do we adapt it so that it does? So hopefully that answered some of the question.
Yeah. Fiona, so just want to clarify for myself, when you just described taking the alerts off of the bedside, did you mean that the virtual nurse was taking the alerts, not that you just simply removed them, but that they were taking the alerts?
I respond to them. Yeah. So the way that we set it up, we have alerts that are in the medical record that will go to staff. And we have some suppression logic within that, so it's not hugely bothersome. But we created a workflow where the virtual nurse would have a list of patients that would have gotten those alerts or will get those alerts. And they screen what we call a system list of patients. So sometimes they're screening patients. They have 9 screens. They can look at lots of things at the same time. The bedside nurse cannot do that, right? They might be in the middle of med pass and they're trying to do that and you're interrupting them. And so what we found was that we were actually answering things in a more timely fashion. We have nurse-driven protocols. So if you have, let's say, a sepsis alert and you've adjudicated it and you feel like the patient meets all the criteria to require a lactate order, then the virtual nurse just does all of that and communicates to the bedside staff that they've done that, and we'll just need to all be on the lookout for the result of the lactate.
And that brings my thoughts to the informatics groups that generally look at this, right? And will say, all right, if you're going to put an alert on, you need to take one off. Which one are you going to take off? Because there's just so many. So this allows you to continue to monitor and work on your quality programs while you're, and safety programs while you're still keeping the burden off of the bedside nurse. And again, that's the team collaborative approach, where we're moving those tasks from the bedside to the virtual nurse where possible. And to someone's point, I can't remember who said it earlier, that the nurses would come up and say, I can do that. I could do that too. People will definitely, speak up and say that they can take on additional tasks from a virtual perspective.
If I could just to piggyback on what Fiona was saying. So it's excellent that the virtual nurses, especially when it comes to sepsis, how it is complicated, they are able to eat that low specificity, high sensitivity, and lead us down the path to only sending actionable information to the teams in the hospital. So that's I love that. And that's one of the things that we've also done. But on top of that, what you're starting to build is an expert group of folks that can navigate the regulatory requirements of even documenting for sepsis. So you'll have your on-site teams that they do have sepsis patients, right? But what happens when you take it virtual? Every patient is a sepsis patient for that virtual team, and they develop that expertise. They become a resource, and eventually it brings the on-site team to rely on the virtual team for this task and prioritize so that they can prioritize other care. So we call them we say it's a bad term, but we call it the death eaters. They eat that low specificity and time suck that the bedside nurses have to deal with. But we have to be careful to not overdo it in the other direction, where we're piling on so many alerts on the virtual nurses that they also get lost in the chaos of alerts. So working with our vendor partners to build and streamline those alert systems and CDS tools so that they can be meaningful on both sides of the camera.
Yeah, I want to jump in real quick too, Michelle, just because I think this leads down a question that we see a lot. I haven't seen it today, but I've heard it almost every time I've spoken, which is around build versus buy, right? And I think what a lot of people are doing is they're using virtual nurses to supplement their poor build, right? They're having high sensitivity, low specificity, as Lisa May alluded to. So this is something I'm an expert in as well. And I do work with groups on developing appropriate predictive algorithms and testing them to see what is their balance between specificity and sensitivity and false positives, right? And all those things, positive predictive, negative predictive values. So when we think about those, really, a lot of times it's okay to use a virtual nursing group as the bridge. And as Lisa May mentioned, those people now become your experts. So I was talking actually to some of the nurses that do sepsis screening with Fiona out at Ochsner at dinner one night at NTI, and they were sharing with me some of the things that they've learned based on experience, right? Situational awareness, because they're screening for sepsis every day, day in and day out, right? They become so expert in detecting sepsis that there's things that they're doing that we need to put in the algorithm, because then we can make that algorithm even more better sensitivity, better specificity. We can do a better balance between negative and positive predictive powers. And that way now we can even be more efficient. Not to replace the virtual nurses and give it back to the bedside, because that's never going to work. It takes too much expert knowledge to know what to do, even with a positive alert with sepsis. I believe that you need to have an expert helping guiding the care and guiding what happens next. So I think that, but they can be the ones we tap into to make the alert better. And so I think don't leave it at that. And Fiona knows this because she's my roommate at a lot of conferences. So she hears me preach. Don't leave it like that. Let's make it even better.
And I think that is the value that we found also, because we actually implemented some sepsis alerts in Delta wave of COVID. And then I live in South Louisiana, so we had a massive hurricane that followed shortly after. And we learned very quickly that our staff could not manage one more thing. They couldn't do one more thing. And I think this goes back to ratios are not it, right? We're not doing this for ratios. We have to balance, what work are you giving the bedside staff? How can you support and share the work? You have to have the right competencies for the right skills and the right skills that you're asking people to do. And Julie can jump in on the staffing guidelines here, because it's not about it. It's about taking care of the patient and making sure you have the right amount of people. So as I tell people, we're taking a computer, it's taking 500 patients and making it 50 using screening algorithms. We're taking those 50 and we're having a virtual nurse screen them and adjudicate and kind of figure out, do we actually need to take action? And then the 5 people that we need to take action on are what our bedside on-site people need to go and do, whether it's our rapid response team, whether it's our bedside, nurses, whoever we've decided at our organization is that on-site person. But there has to be a way that you are decreasing the burden that's going to the staff. And then what we also did was, as our virtual nurses were learning, because we just had 5, we had 5 that learned how to screen really well. As Teresa said, we were able to better use the tools and adapt them, because some of it just didn't make sense. And so we had a very receptive IT department that were able to, we said, this isn't going to work. We got to fix this. We got to fix this. And ideas that those frontline staff had of how to document and how to track. And we were able to flip that really quickly, because we didn't give it to 1,000 nurses, right? We didn't give an alert to 1,000 nurses and hope that they did something, right?
Yeah, sorry to interrupt you there. Not mean to. There's 2 open questions, and I want to make sure that we get those answered as well. One is related to a prior conversation. So Caroline, I have that one for you. In the scenario discussed where the virtual nurse pairs with the clinical nurse and CNA, does the virtual nurse have the same assignment, or do they support more than one clinical nurse?
That is a great question, and it is up to what your unit decides as your model. So there's different ways to be creative with the virtual nurse, but one of the first things that we do, whether it's a telecritical care unit or an acute care unit, is we ask the unit, what are ways that the virtual nurses can help you? And the unit comes with pretty much the same answers, and we look at their answers, and then we create what are the primary interventions or expectations that you would like your virtual nurses to do when you're first starting the program. So find your primary interventions, your expectations. For example, it can be admits, discharges, patient education. And then later, when your virtual nurse team is more competent in documentation and working with the bedside, you can add the secondary interventions like checklists, calls to the OPA, coordinating other care, other teachings. You can add those as secondary interventions. And the reason why I suggest tiering your interventions when you're first getting started is that way you can flex what your model, your assignment looks like. So if you have a unit, for example, that has 30 patients and you're only using one virtual nurse, then you may only want to have that nurse support the unit with primary interventions that your unit decided. And later on, if that nurse decides to have an assignment where they're splitting the unit, there's 2 virtual nurses in the unit, then you can add on the secondary and more advanced interventions that you would like the virtual nurse to complete. So with that being said, identifying the types of interventions is helpful, so then you can flex based on how you're going to assign your virtual nurse to your unit. The third part of it is some units just have their nurses work with patients. The nurse and the CNA they're assigned to that nurse and another nurse, because usually usually there's, for example, 6 nurses in the units. They would, the virtual nurse would work with 3 of the nurses, and the second virtual nurse can work with the other 3 in that assignment. So it just depends on what the unit's needs and what your accomplishments and expectations are with your virtual nurse and your CNA model. And as your program matures, then you can add more advanced interventions that the virtual nurse can support. So I hope that answers your questions in different ways. So it's a time for us to be creative and innovative. There's not one good answer because all units are different. You also base it on not just your boots on the ground, but you're also looking at your patient population. Like, does it make sense to split the unit and your virtual nurses with the dyad, the bedside dyad, or does it make sense to have the virtual nurses just focus on a few things and serve the whole entire unit? So it's up to your unit what your goals are.
Okay, ladies, it's time to rip the Band-Aid off. Let's talk about vendors in the space. And let's talk about staffing models, what we've heard. And I should say to any of the participants as well, any other Q&A, we're answering them live as well as in the chat or in the question themselves. So you should be able to see those responses, and they will be recorded as well on this recording. Let's talk about the vendors. There's a lot of vendors in this space. It's hard to know who's in the space today. Just like we saw with the Teledocs and the Amwells, there's a lot of great salespeople making a ton of urgency where there is true urgency with burnout, but making urgency around it, defining models in a way that maybe we need to really speak to the experts like the MVP panel we have today. So let's talk about what is what are you seeing from the vendor market? If you were advising the folks and the providers that are looking to make these decisions and try to decide how they pick a vendor who will be ideally a partner in making those systems work for them, what advice and guidance do you have for them in your each of your illustrious careers? And I'm going to jump to you first, Fiona, and then we'll kind of go from there.
I think for me, I think it goes back to use case. Like, you have to know what you're trying to accomplish, because I think there's a menu of things that people deliver or say they can deliver. I'm not sure they can all deliver on them, quite honestly, and probably in varying degrees. So I think you have to start with what problems are you trying to solve? What do you want to get from the vendor? And you need to go with that to you need your checklist, your own internal checklist of what you're trying to accomplish, and have that ready. And then as you go to the different vendors and the different solutions and technologies that are out there, you need to see the pros and cons of all of those and which ones actually match your needs. So I think that's pretty basic, but sometimes we get a little bit blinded by science. And so, we forget what we originally started out with as the problem.
Exactly. Teresa?
Yeah, so I think it's really important. This is such a great question. And I know that somebody else had asked one similar. I was trying to find it real quick. It was related. Yeah, it was related to doing this in long term. It was Deborah Graham, where she asked about virtual nursing and long-term care, and then about contracted services. So when do you know when to, again, do this in-sourced or outsourced? Am I going to outsource and use another company to supply my virtual nurses, or am I going to try to in-source and build it within? Really depends on many factors. One of the factors is regionally, are you suffering from a nursing shortage where it's going to be really hard to find nurses in your area to do this work? Are you going to end up having to basically compete with the bedside and take nurses away from the bedside in order to have a virtual nursing program? Or maybe you have a shortage because your expert nurses left. Can you re-recruit those expert nurses and bring them back, right? And use some innovative staffing models to get them back. Do you have the expertise for whatever it is for the gap you're trying to fill? Sometimes you can use an outsourced model as a bridge. Maybe you're going to, while you figure out all those things, you need to do something now, right? So you outsource and you find a partner that has virtual nurses that can do the tasks that you need them to do, or virtual nurse practitioners and intensivists. Maybe they have the whole team for you, and you can use them to assist you with filling those gaps right now today as you build your program. So again, it depends on where you're at and what you're trying to do. From the long-term care facility, that's a tough one because you have shortages of nurses that are greater than what we're experiencing on the acute care and hospital side. In fact, we steal your nurses. We did it during the pandemic, right? We stole your nurses and we brought them to the bedside in the hospitals. We could pay them more money and they all left you guys stranded. And so it's going to be tough for you to staff that internally, most likely. So unless you're going to scale it by turning it into a business. So you're going to start the program and then you're going to sell your services to other long-term care facilities, then it's going to be difficult. But there's a lot of people you can partner with. It doesn't have to be a company that sells this. It could be an academic medical center that has a centralized unit that's providing telehealth services that can help you.
Yeah, and actually have experience with that. In my prior life, we did partner with our local nursing homes, and we provided the virtual nursing to the nursing homes that were having a high turnover of patients or bounce backs into the hospital. And so we had a triad: our hospital clinical team, our virtual team, and the team in the nursing home. And we provided them with an iPad on a stick. It did not have to be fancy, but we had what we decided that we needed to have the same goal. And that goal was to reduce that unplanned rehospitalization, because we had a lot of patients coming back for things that, you know, were really unnecessary had we been able to intervene. We got all of our even our providers credentialed to be able to write orders in the facilities, and mostly at night. So to Deborah's question, it's a great question. And truly, there is no limitation on what the virtual nurse model can accomplish. It's just back to what Fiona says, what you're trying to solve for, you know, what needs are you trying to meet? And when it comes to the vendor, looking at their integration with your EMR should be part of the conversation. Also, it should be part of the conversation of how much manual effort will it take for the virtual team to be efficient, because the last thing you want to do is to bring a product in where the virtual nurse is spending a lot of time clicking and documenting and less time doing what the meaningful stuff that will help with the patient care. So you know, I had this conversation with a vendor when I was at NTI, because a number of nurses did mention this, said, are you listening? Is your tool able to consolidate all of these steps and processes that we need to accomplish and highlight for the virtual team what we need to do in order to be a benefit and help to the on-site team? So working with your vendors is a partnership. Yes, that's not breaking news, but we need to remember that it needs to come from what the workflows are and how those workflows will drive what the solution or the technology will be, and not the other way around.
I think we talked a little bit about how often vendors are going to what the market is telling them, or they think is telling them. They're trying to, as what I described, is go into where the puck is. And the thing that nurses are doing, the process that nurses are doing, is they're actually trying to get to the Stanley Cup. So we're not just trying to get into that next play, we're trying to get all the way to the championship games, right? So how do we, and I put myself in this we, like I'm just getting, you know, osmotic nursing from all of you. But I did note that Teresa corrected me, and I'm glad she did so nicely about the alerts, by the way, that didn't miss me. And I'm happy to be corrected. But that being said, I think we found that having the vendors understand exactly what nurses are trying to do from a workflow perspective, operationalizing that's the kind of vendor that is partnering with you. As you said, not big news, but that's what partnership looks like. It's not, here's my work plan, here's my staffing plan. And I'm jumping in here because these are one of my passions from an IT perspective. It's not what you want to see in terms of the, you know, 30,000 foot fly by and then they're out. You need them to be working with you to help you understand how this is going to affect your workflow, what changes are going to have to happen within the operations of your organization. I would say also on, and I'm jumping in on these two because again, they're my passions, but also on the cost of care. For those of you that are looking at these patients that are bounce backs, that are nursing home potentials, or any patient that's a costly patient within the organization, those are reports and information that you can get today and see who those patients are that are contained in your ACO. And you want to reduce those high-risk patients, reduce those rising risk patient costs. Those are direct costs as well as direct revenue sets, because institutions generally have a bonus associated with that from the payers if they're able to keep the cost of care down. And for those bounce backs that are coming from the nursing homes, if you're in that industry, then you're able to define exactly what the cost improvement will be based on the fact of there's X amount of bounce backs, and this is how much cost we will take away by not having those bounce backs, or helping you to manage those bounce backs in a better way. Okay, so last but not least, before we get flooded with additional questions as we wrap up our last 15 minutes here from the group, tell me a little bit about what your future state looks like from a virtual care, virtual nurse perspective, and how is that going to take us to the next level? Does that include AI? Does that include, machine learning in our systems? Does that include more? What does that look like? And how do we train the next group of nurses and clinicians on these technologies in order to make sure that we do meet the future and we future-proof our plans today? And Julie, I'm going to start with you. Julie Reister, I'm going to start with you. I said I would be specific. I haven't been always. Julie, I'll start with you, and we'll kind of do a round robin.
Yeah, just a couple of quick comments, and it even kind of addresses a little bit about your pull off the Band-Aid. What are you seeing? I think one of the things that we're seeing a lot, and you have to really think about, is there used to be, and there still is to some degree, use case specific technologies. This vendor does remote patient monitoring. This vendor does virtual sitting. This one does, specialty consults. So, I think that that's a word to the wiser than we were out there, right? To be thinking a little bit more broadly about that. And then the other comment that really I was, going to make earlier, but it's relevant to your kind of final question right now, is I believe that all of this is much more than a two-way audio video connection. To Fiona's point earlier, and one of the things that I found incredibly powerful years ago with some of the technologies we used is that, if you believe part of the role of virtual nursing and the team is to identify adverse trends and intervene before adverse trends become adverse outcomes, you've got to have a level of sophistication in the technology that does it. To me, it's not just about trying to figure out when I'm going to do video rounds or when I'm going to do documentation rounds. So that really, I think, starts to lead to, everybody asks every day, oh, well, do they have AI? Well, we're not going to kind of dive too deeply into that, but I think that my point being is that we have to be really mindful and thoughtful about how all of the information that is available to us can be digested and served up through that platform to do things like Fiona talked about. We had hundreds of patients, hundreds and thousands of data points, but if you have software that can identify that, curate that, and bring that forward so you can focus on those patients, that's incredibly important. So again, think about broadly what your technology is going to be and be very careful, I think, of use case specific vendors, and also really be thinking about more than the two-way audio video connection and how this rich data that you're going to get is going to be served up in a way that can really benefit the patients and the team.
So well said. And Fiona, Julie invoked you, so I'm going to take you next. But one thing we didn't mention was something you said in our prep call, which is that virtual nursing actually opened up new pools of resources for the organization and how that was able to help you to address even a resource need that was already existing within Ochsner. But what are your thoughts on the future state?
Yeah, so I think just to echo Julie, I think we have AI, we have this, machine learning. I think we'll get to closed loop, feedback at some point. I think we won't always need the human all the time for all of the things, but I think we're not there yet. And in order to make the AI better, right now you have to have a human because it's not that smart. It'll probably get there, but again, how will it get there? The only way it gets there with human interaction. So I think that piece is going to be critical. We've done different types of AI alerts, and they all require human adjudication. From a workflow and what you just alluded to, in COVID, obviously, we had a very huge nursing pool that was short. So we were very acutely aware that we could not take any staff from the bedside. So one of the things we learned was that we have several pools of nurses that we are not tapping into. So do we have enough registered nurses in our states to be able to take care of the patients? Maybe. Are they all working in nursing? Maybe not. Are they licensed and current? Maybe not, because we have lots of people that have aren't able to get to the bedside. They may be older and have massive amounts of experience that we're not tapping into. Are they perhaps taking care of children or taking care of elderly parents? And so they have specific timeframes that they can work. And so what we found was that you can do some of the virtual work for 4 hours, 6 hours. It's adaptable, it's remote. Like, we can do a lot of things where you don't have to do a 12-hour shift. And so that's where we were able to take advantage of light duty nurses, et cetera. So I think it actually opens up pools of staff that we haven't tapped into and potentially could. So I'll leave that for other people on the call to address.
I'd like to piggyback on that, Fiona. During the pandemic, within the first 2 weeks when the public health emergency was announced, we quickly contacted nurses who were unable to work at the bedside because of different reasons, immunosuppression, also light duty nurses. But we had to quickly address the problem before we knew what was going to happen in the short-term future. So I always love to use our example of COVID home monitoring, and that's where we took nurses across different states to work remotely to provide surveillance to nearly 30,000 patients across our enterprise footprints. And it is so amazing what you can do with the technology that you have. And we worked like bare bones, but we gave so much opportunity for nurses who needed to stay in the profession, and nurses who, we cut a lot of our elective surgeries during that time. So there was, even though we had a shortage of nursing, there were a lot of nurses who couldn't work because surgeries and visits were decreased. So that's when we went forward looking, seeing what materials we had, the technology that was existing, and created this super huge workforce across state lines to monitor patients. And I just love that story, because when I look back, I can't believe how crazy it was and how many people we were able to get in. And in that time, it's not like we had AI or any special algorithms. We went back to the basics of nursing intervention, surveillance, using our assessment skills that we can use for technology to provide care throughout our system. And that's like a warning for vendors and things like AI. Just because you have the shiniest, newest thing, it all comes down to the basics. What are your needs? What are your priorities that you can use with the nurses in your system? And how can we use other nurses to get them back in that may not be in the traditional bedside role? So yes, technology is here. Yes, AI is here, but just because it's the newest and the best, sometimes you don't need that. And you need to look at longevity for nursing careers, because it's beyond the technology. It's the expertise that you have, where you're creating more opportunities for nurses to perhaps get back into nursing in a different way and to utilize their years of experience. We've lost a lot of nurses because of the pandemic, but if they're hearing more about virtual nursing, they're coming back and they are appreciating their work a lot more, because they can spend more time with their patients, things that they weren't able to do when they were at the bedside. So that is looking at longevity for that particular nurse. And we hope that this is another opportunity for all nurses to have that option to stay in the workforce, because we have to supplement the bedside with virtual working together, no matter what the new technology is. So going back to the basics and thinking about longevity for our nursing careers.
That's so good. Thank you so much, Carolyn, for putting that in. I'm going to go real short because I know we're running short on time. Got a couple other folks I want to make sure get a chance to talk. But just building on what Carolyn said, the reason Carolyn could step in and assist with guiding that is because she has many years of experience doing this. So she knew how to put a team together quickly and how to advise other people who were putting that team together on the technologies that they needed and those that they didn't need to worry about, right? And so I think it's really important that if you have the internal expertise within your organization, tap into it, right? Do not think you can do this by yourself. If you have a telecritical care unit that you've already been working with, tap into their skills and expertise to help guide your program if you're doing something outside of them, or partner with them, number one. Number two, if you don't have the skills and expertise to determine what tools you need, and I did answer Stephanie's question, so you can go in there. I put an excerpt from a book I'm writing around what kind of equipment you might need. But if you don't have that expertise, then tap into somebody who does. And that's what we do at Blue Cirrus. Is we don't just do these webinars, which we love to do for education, but we're here to help you. So just, take a look at my response in there and realize that you don't have to have all the answers, because there's people out there who can help.
And Lisa May, and we'll wrap with you.
I could not have said it any better. However, as I was listening to everyone, and going back to what we had said earlier about nursing is nursing and virtual nursing is here to stay. I do see a future where this is part of the continuum of care. It's not going to be just when the patient is in the emergency department or in critical care or med surg. It's going to be a specialty of experts that are available throughout the continuum of care for the patients. And how we build with technology is going to be defined by how our nurses are seeing their role in themselves within this continuum. And I did hear one talk where AI came up, and the discussion was more about that it's more of an assistive AI, where the technology is assisting in us working with patients and nurses in the on-site world to be more efficient and optimizing that care. So for everything that was said today, the bottom line is that whatever we do as nurses will be defined by what our patients need, right? And who our patients are, it doesn't really matter. It's who your nurse is that really matters. And then as long as we're matching the right nurse to take care of the patient. So essentially, virtual nursing is leading us down this path to really look at our profession in a new and exciting way, and moving us in a direction where we are seeking to have better outcomes for our patients in the long term.
Good points, Lisa May. And Julie, what are you and your
all I want to see is a healthy work environment on both sides of the camera, and outcomes being measured and published. Looking forward to it. Every virtual nurse deserves a healthy work environment. Every nurse who's working direct care at the bedside deserves a healthy work environment.
Absolutely. Thank you so much to my panelists. Carolyn running to another meeting and just dropped off, so just in time for her. Thank you to all the attendees that stayed for this hour and a half. It was so much information packed in there. If you didn't catch everything, we will have it. We did record this, so we will have that on our website in the next day or two. Thank you to Julie Miller, who continually put resources in that chat and those Q&As, so people can always go back to that. Fiona, for your excellent advice on how to optimize this stuff and how to work with your systems people and make this work for your nurses and your patients, and being that liaison between, obviously, Julie, your executive experience. And I hate to just say that because I know Lisa May and Teresa have the same level. Thank you all for putting up with me and my interruptions as I added my own 2 cents. One thing I will say at the end here is we will be having that part 2, redesigning systems for virtual nursing success. We'll include several different topics, but if you have any others, when you answer the survey post webinar, you can certainly include any topics that you think you want us to include in that part 2. Secondarily, think big on virtual care. You heard it from everyone here. This is not going away. It needs to be threaded through everything as part of a holistic care. I know Julie's really passionate, and we didn't talk about it. Julie Reister is really passionate about the remote monitoring piece, and we heard how impactful that has been. But think big on those spaces. Don't just accept what you're hearing from the vendors. We can tell you from our own experience at Blue Cirrus advising people, you always get, well, we can't do that with this vendor. We can't do that. Well, then why are we wearing the shoes that don't fit anymore? And I know that changing a vendor is expensive, but so is, managing your patients over time. And we do need to continue to think about that in future state. And then nurses and clinicians in this space, you have the power to be able to communicate that to leadership and use your voice. So thank you all. I appreciate it. Have a great rest of the week.